Welcome to the weekly series of Healthcare Scene Google Plus Hangouts, where we sit down with the top leaders in healthcare IT. Before we begin, I want to remind those watching live, you can tweet any questions you have to the account at EHR and HIT, and we'll respond to them. And plus, we're testing out a new Google Plus Hangout application where you can submit the questions right on the screen. So if you're joining us live, feel free to submit those questions. We'll try to incorporate them in. But today we're excited to have the always insightful and one of my good friends, Dr. Nick, who's CMIO at Nuance Healthcare, with us. I'm pleased to have you here with me today, Nick.
Always a pleasure, John. You're very generous with your compliments. Thank you. I reflect that back to you. It's always fun to be with you, and I appreciate the opportunity.
Thanks. I think this is probably our third or fourth video. So you're my most common guest, and I always enjoy it. So let's start the discussion talking about a few kind of hot health IT topics. And the first one that I think is interesting is that we've seen numerous calls for a delay of meaningful use stage 2. MGMA put something out, HIMSS put something out, Chime put something out. All the major organizations are calling for some sort of delay or some sort of change to meaningful use stage 2. What do you think of these calls, and where do you think it will go?
Well, so you have to lend a tremendous amount of credibility given the organizations that are calling for it. I mean, that's not a small request coming from any of the ones that you named. I have to be honest, I think it's inevitable with what is, just enormous change in a healthcare institution that has been struggling to resolve many of the challenges that we have that are essentially hard deadlines. We've got this exploding population of aging folks that are requiring more healthcare. We've got a declining population of healthcare providers for a number of reasons, declining resources for a number of reasons, and all of that combines on top of what is essentially a pathway that was set out a number of years ago that says we see meaningful use as a way of sort of resolving some of those issues. So I think it's inevitable. I guess if I was to be on one side or the other, I would be less inclined to delay, in part because I think it's sort of, it's letting the challenges win, where I think, with the innovation and much of the brain trust and the energy and all of the people that I engage with, I think, that concerted effort, it's a bit like plutonium, distributed around, it's interesting, it's exciting, but when you gather it all together, something really exciting happens. And, I saw that this week on Monday at the National Health IT. Farzad, I know, is retiring. He's been a great leader. I know we're going to have a great individual that will take his place. I don't know who before you ask me. So
no predictions, okay.
But I think that, it would be a shame to lose that momentum, whilst I respect those individuals, and, we saw a delay in ICD-10. So I'm a little bit on the favor of, persisting and struggling and trying to march through, because I think it's such an important program and such an important part of resolving some of the challenges in healthcare.
Mm-hmm. Yeah, I mean, I think the best argument that the organizations have made for the delay is really around the slow pace of getting the EHR certified. So they're not certified quick enough, and so then if they're not certified quick enough, the end user can't get it quick enough so that they have time to actually meet the MU stage 2 deadlines. So I think that's the best argument I've heard made, and probably why I think it will be delayed. But I guess we'll see how those timelines play out.
Right, and that wasn't the question you asked me. You didn't say, do you think it will be delayed? You said, what?
So do you think it will be delayed?
I think there's some very compelling reasons and arguments, and you cited one of those. And I guess, history isn't always a predictor of the future, but given that we saw a delay in ICD-10, and I personally, prior to that, I would have said, no way. So I think there's precedent, and maybe some good reasons potentially to do so. But yeah, probably, I guess, a little bit on the other side of it's likely to be delayed given the history, but my preference would be for it not to be delayed. But that's, a little bit of I guess, a balance on those two positions.
Yeah. Yeah, I mean, many of the EHR vendors that are already certified are saying, well, maybe those ones that aren't certified shouldn't be, blessed with a delay so that they can get around to it or whatever. I think, there's multiple arguments on each side. So.
Right. Right.
So how about moving on to another topic that we just keep discussing over and over, ACOs. Have we really made any progress in understanding what an ACO is?
I think there is. We're still in the early stages of it. What I hear repeatedly is the reference back to it in many of the presentations, many of the discussions, as a good pathway to changing the reimbursement model that exists in this country. So it's very clear to me, and maybe not for everybody, but I think the reimbursement model is a foundational challenge in the U.S. system. We pay people to do things, not to make patients better. And central to sort of resolving that is the ACO challenge. Now, that's a complex model, and it starts from, I think, a very early stage. In part, we don't have the data. One of the challenges of measuring that is how do you determine whether we made people better? It's not just, births and deaths and, some of the very basic measures. So I think it's still early days. It's probably slower than you would expect, but that's inevitable given the complexity of this, and what a huge change for the healthcare environment. But I think overall, yes, I think part of it is messaging and getting that message out to clinicians, getting it out to providers, patients, to say this is a good thing. There are some negatives associations with ACOs and this concept of managed care. I think people are sort of, well, that's just managed care. Yeah, no, I think it's a little bit richer and smarter than that. And I think we're seeing a number of test sites and areas that are exposing the world to those concepts. And overall, wouldn't you rather be in a system that treats you to get you better than treats you to do things to you?
Mm-hmm. Yeah, no, I mean, I think you highlight the challenge, and I heard Farzad one time say that unfortunately the two systems of reimbursement can't coexist. Yeah. You can't do a fee-for-service and a ACO type model together. So the question I have is like, well, what's the pathway to make the switch, right? And like if you have to turn one on and turn one off, right? Is there a pathway?
That's not a pathway, and that's a cliff on both sides. What? We're on this. So I don't know. I mean, I think that's true. If you've got the fee for service still in existence, then I think the challenge is it's going to be hard to wean people off that cash flow. Maybe it's going to be a hard deadline that says this is the crossover point at some point, but it's still, to me, it's early.
Yeah, can you imagine a deadline? Every doctor wants to hear. So speaking of deadlines, ICD-10 is upon us. Are we ready? Do the organizations you talk to, are they ready for it? Or are they kind of, is it like Y2K where we're talking about it and nothing's going to happen, or is it going to be, kind of surprise us with all sorts of issues?
Well, so I thought about this a little bit. You were kind enough to share a couple of these sort of broad areas, and I did. I thought about this one, and to me the obvious answer is yes, of course we're ready, because we have to be. I mean, how can we not be ready, given that we're not going to see it? I absolutely can't see another delay. So we'll be moving towards it. Is there going to be some hiccups along the way? I think that's probably a fair bet. I don't think it's quite like the Y2K bust where, oh, it's Y2K, the world is ending, and the clock ticked and we all looked around and go, nothing's changed. There is some significant changes, but I think there's been a fair amount of preparatory work. We did have the delay that, for some people was a huge benefit. They used that extra time to prepare. For some people it was, oh great, we don't have to work on it yet. That's not the idea. From a company standpoint, allowed Nuance a chance to prepare and bring together the right resources that we can bring to bear for our customers to allow them to be prepared, so that I think we're well positioned to do so. I think many are. It is troubling the number of people that I do come across that, you know, sort of, yeah, we're getting there, but they're not. And I think it's a deadline that's going to affect and impact people financially, because when they switch over, they're saying, that's it, you're done. You're going to have to be over on the new system, so better be prepared, otherwise you're going to have some significant challenges.
So I mean, you know, we titled this talk talking about, you know, technology and the shift to focusing on patients. So, you know, I mean, let's kind of shift to that topic a little bit and kind of sit with the ICD-10. You know, are there patient benefits to the use of ICD-10? Or, I mean, you come from Europe, so you know, you've been using it forever, right? Are there benefits to it, or is it really clinical?
You know, I think absolutely. I think it's easy to discount it. There's been an awful lot of coverage of the sort of, you know, obscure codes that who would ever imagine that somebody would be injured water skiing and catching fire. I believe that's one of the codes, and you know, it's easy to make light of that. I focus on the positive of it, and you know, you're right. The rest of the world moved to ICD-10, you know, some significant time ago. And number one, it gives us a much more international capability to compare our statistics and, you know, get to a level of granularity that we can't with ICD-9 when comparing to other countries. There's no sort of crosswalk of those codes. But from a patient perspective, I think, you know, specifically as we start to think about quality of care, those quality measures, you know, rule number one in quality, you can't improve quality if you can't measure it. And ICD-10 was never really well positioned to be able to allow for that. So from a patient perspective, I think some of it's a little bit hidden because we don't, you know, as a patient, I don't care about codes except, you know, maybe in my explanation of benefits, I look at codes and, you know, I wonder what that is. There's still going to be some challenges with the terminology, but from a quality review standpoint, and I think with some of the tools that we'll see that will help, you know, explain and allow patients to understand that better, they're going to see more detail. And that's important as patients, and as you know, I'm a big proponent, and I think you are, of that patient engagement. Having them involved and being part of the care process is essential. They can't be part of that process without data, and the data currently is locked away in codes that are less or certainly suboptimal for that process. So I think absolutely yes, benefits for patients. I think true also for clinicians. I think clinicians sort of see it in a, you know, they're frightened by it because, oh, I'm going to explode my codes by 7x.
Yeah.
The reality is, you know, let's pick on something that's talked about frequently. People talk about, oh, laterality. Oh, come on, really? How many clinicians don't know whether it's the right or left? Of course they know. They just, you know, we're going to codify that into a term that allows us to then compare. So, you know, there are some small additional elements in, you know, that code set for a single condition that maybe we know, but we might not have captured or documented appropriately. So there is a little bit of, you know, feedback that's necessary to clinicians, and that's part of the key, is to give clinicians feedback at the point of documentation and treating patients. But then, you know, what we're getting is better information downstream for clinicians who all complain, oh, you know, if you're going to compare me and, you know, review my quality statistics, you're not comparing like with like. I see more complex patients. Well, unless you can show that, you can't prove that point. With ICD-10 and that expansion to codes, now I'm going to be able to say, hey, you bet, I've got a more complex case mix, and therefore my results will be different appropriately based on the difficulty of the cases and, you know, the corresponding conditions that are included in my patients that I have to take account of when I care. So I think it's going to benefit all the communities. It's just, it's a little bit challenging because it expands the requirements for capturing that information, and the burden has historically been placed on clinicians, and I think that's why they resist it. oh great, I'm going to have to learn more codes and be able to capture that information. Yeah. Technology is absolutely key to resolving that issue. So we're going to remove the...
How does that happen then? What's the technology piece that will make ICD-10 easier for clinicians?
So I obviously coming from a speech company, speech recognition I think has proven its point. It's reached a tipping point for clinicians. We've got 500,000 clinicians using our technology. The piece that's been layered on, and we've been working on this now for about 3 or 4 years, is natural language processing, or as we call it, clinical language understanding. We can take that narrative, unlock the information, turn it into clinically actionable data, and apply medical intelligence at the point of documentation, so we can not only provide the feedback to the clinician to say, hey, from a coding perspective, we need some additional information, but more importantly, one of the things that clinicians really want is feedback that's useful about the quality of care. So I see a constellation of symptoms in that documentation, but you didn't mention a specific condition, or you didn't document it in the way that's required for that back-end process, which I as a clinician am not as well connected to. We can bring that to bear real time, and we can do it with technology so that it doesn't become burdensome. Right now that process occurs downstream. It's, can be hours, days, or even weeks later. Who can remember what happened 5 weeks ago with the patient? That's very difficult. We can bring it, we can do it real time, and importantly with technology and the clinical language understanding, we do that in a way that is more efficient. Technology gets faster, better, more accurate, as we did with speech recognition, so we're bringing that whole process to the front end. And every clinician that I talk to about this is excited about the real-time aspect of this, not the back-end process, because they all say, if you ask me now, I'll be able to answer it. If you ask me in 5 hours, it's essentially a logarithmic curve of declining ability to remember that information.
Sure. I mean, even using your right and left example, I mean, if in real time you start to document something and then you forget, was it right or left? But it can already tell you using the clinical language understanding or NLP or whatever to present that documentation to you at the time, because that may be something you don't remember, but you documented it, right? So yeah, that's interesting.
Absolutely right. So most people would say, well, that wouldn't ever happen. Of course, remember right or left. It's not true. So we have a specific product. It's called Assure in the radiology world, and you go, well, how would you not recognize that it's right or left lung or whatever it happens to be? Well, here's what happens in a busy radiology department. I'm documenting. I'm looking at an image and producing the report. Somebody comes and says, I've got a hot seat report, I need a quick report, and I switch over and I start talking and give them a consultation, or maybe the phone rings, or I have to go and prep a patient for contrast or whatever it happens to be. I come back and I can potentially mix up that right and left from another patient, and it's easy to do with these screens. You don't know whether you're in that report or another report. And what Assure does precisely that. So it checks for references of right and left, so laterality. It also does gender-based content and a number of other parameters that we can automate, search for, and say, oh, wait a second, we think there's a problem. There's not a clinician on this planet that doesn't say, yeah, that's a possibility, and I want that because it's not something that I would actually do or think about doing, but it's going to happen. And it's happened to clinicians, and we've got technology that's now sort of sitting. It's like having a quality assurance person sat behind you. No, wait, doc, you're on the wrong one there. So we're doing technology, or using technology to sort of improve that overall quality and try and prevent some of that.
Right. Yeah, and I guess the key challenge is balancing the false positive notification, so you don't.
Absolutely. Essential to make sure that you don't notify when there's not an appropriate reason. And some of that is a balance of how you notify. I think we're still learning about user interfaces. I mean, I'm it's distressing to me how poor some of the user interfaces are. I think there's much more work to be done, and we haven't included the user interface experts in many of the designs of some of our systems. Yeah. We focus on that.
Sure. But kind of going back to your other comment about ICD-10 for patients and really kind of that movement towards giving patients access to the data. I mean, even the ICD-10 codes or other data. At a recent, I saw a recent tweet from the Epic user group meeting. It asked the day, or it actually stated and then asked. It said the day is near where patients are the highest volume users of your EHR, and then they said, or is it already here? Which I thought was an interesting way to look at it. I mean, do you see this trend happening where the patients are the EHR users as much as the doctors or nurses or front desk?
Historically, I think people saw this as, doctors' notes, it was the hospital's EHR. I come at this, I have a pretty strong position that I think it's the patient's notes. For me, the most compelling reason to open that access is when you consider the biggest vested interest. If you're in a room with the physician, who has the biggest vested interest in the accuracy of that note and the ultimate result? Well, it's the patient. That's an untapped resource from a quality assurance standpoint, and it's an untapped resource for engagement and inclusion. And one of the success factors of any healthcare delivery is engaging the patients, because if we just hand out the prescription and that's the beginning and end of it, we know what the end result of that is. We see this big drop off in usage of prescriptions and treatments because people are not engaged. If we include them, and the EHR is part of that. So I have two answers. I was at the National Healthcare IT Week, the patient engagement piece on Monday, right. And you couldn't be sat in that room with all the presentations, the examples, and this brain trust of people that are really driving it, some real standout folks that are really making this happen, and not think, hey, we're there, this is really happening. Of course, that's a small subset of reality, and I think I don't think we're there yet, but I think that is absolutely an essential part of the future, and needs to be part of any clinician's view of the world, is including the patients as part of that process, just from a quality assurance, but from an understanding perspective. If they're reviewing it and they don't understand it, if they read it and don't understand it, I'm willing to bet that when you told them they probably didn't understand it. Having both components as part of that process improves patient understanding, will improve their overall outcomes, and I think we're going to see an improvement in quality as a result of it.
So I mean, I agree. I think we're moving that direction. It's interesting when you go to a conference like that and it's all hunky-dory, everyone's doing it, right? But to me, it seems like the biggest driver towards this type of engagement is meaningful use. Stage 2, which requires it. Right. Are you seeing that, or are there other drivers where you're seeing people adopt it even?
Well, I'm going to pick on a specific presentation. Farzad, got a big kick out of introducing the office. Now I'm blanking on the name, but civil rights. So the Office of Civil Rights, and he introduced the leader of that group, and essentially he stood up in front of this audience and said, it is your civil right to have access to your notes. There is absolutely no reason, and if you are having a problem, please, here's the process, here's how you deal with it. There was a printed sheet, there's a reference, and he pointed out, interestingly, I didn't know this, that the biggest fine that they have issued and this is embedded in the HIPAA regulations, was for failure to share information appropriately with patients. For me, there's nothing more compelling than dollars behind these promises of sharing information. And we were filled with stories of people that have tried, had failed. Pretty much as soon as you raise the Office of Civil Rights, it's funny how that whole exchange. It's the civil right, and for 20 years I've been gathering, and people are always suspicious, and I always have to explain, hey, I've traveled, for 25, 30, for most of my life I've traveled multiple countries, so I carried my medical record. It's paper, it's now digital, I've scanned it and, improved on it. I consider myself a poster boy in that perspective, And what's good for me is absolutely what should be good for everybody else. So I think it's well on its way.
So, I mean, that brings up an interesting point, right? I've heard a lot of people make the argument that HIEs are a failure, and the only HIE that will work will be the patient-controlled medical record, kind of what you described, right? Where the patient has aggregates all of the records across all of the doctors and then provides it to the next doctor they go to. Yeah, I mean, is that a viable model for the masses, or is that just someone for a healthcare freak like you, right?
Well,
I say that affectionately, healthcare freak.
so taken. I think that the challenge with the exchanges has been the funding. That the major problem has been who's going to pay for this.
Right.
It sort of got some seed funding, and the number of them that sort of launched and then they failed to sort of thrive or continue. The question is, will patients or are patients willing to pay, or is there some model that allows them? And it's hard to speak for individuals, but as you become more engaged, so I think one of the there's a number of things that have to happen. One, related to the ACOs and the payment model. Right now, I go to my doctor, somebody else pays the bill, I get a proportion of it, but that proportion is changing, and certainly, my own personal insurance with Nuance has changed, and I have one of these high deductible, and I have a spending account, not one of the funky ones that you use it or lose it, which I think is a little bit perverse, but the one that gets to save. So now I've got a vested interest, and I pay pretty much everything out of that, but I'm saving lots. A health savings account. Right. That makes me much more focused on running and managing the costs. And I think as people become more engaged, so there's now I've seen I'm using tools that start to present that information to me, and I think the same will be true for patients. And as they start to see and feel the cost, they're going to ask those questions and want to be included in that whole discussion, and that's what's going to push us over the edge, because now suddenly it's no longer somebody else's dollar, it's now my dollars, and we become appropriately price sensitive, but quality focused as well. I want to get value for money. It's not just about the cheapest, I want the appropriate choice.
Right. No, it's interesting for me. I mean, obviously I live, eat, breathe, and sleep this area, but yet, I haven't seen the need to aggregate my record, and my wife has had some issues recently. It's like, oh, maybe that would be enough to start aggregating. But it's kind of like, what would I aggregate for myself? My record is no allergies, no procedures. You don't need to know about my cold and flus that I've had, right. Every 4 years, right, or whatever. So, anyway, it'll be interesting to see how it evolves for people to care. Although I'm on a high deductible plan too, so I care more like you described.
Right. So some of that's age related. So you're a little bit earlier in the phase, and as you age, you'll be impacted by some of those other things that will inevitably So some of that. So as we see that aging population push through, they're going to demand and want that. But the other thing, for me, the most compelling thing for people that are younger is, how about the first time that you go for anything that takes more than a single visit to a single location, and even if it's the same location, I can't tell you the most frustrating thing that I experienced when I first arrived in this country was filling out this 4-page fact sheet on myself 15 times. Yeah. I mean, I'm sorry, but that's preposterous. If you can't share that information and just pull it down from somewhere, that's ridiculous. It really is, and I think that's an important aspect of this.
Yeah, I mean, the problem is there's no solutions to that paperwork, at least for now. I know a dozen companies that have tried to work on it, but so is Nuance working on some patient-focused initiatives that around this? Or, I mean, I know you have a whole suite of tools for providers, obviously the voice recognition, the ICD-10, the clinical language understanding, but what type of tools are you working that are more patient-facing?
So I think on a number of fronts. So one, in terms of freeing up the clinician to focus on the patient, I think that's the passive capture of that information, The story that I describe repeatedly is, focus on me, not on the technology, and that's part of that passive listening. We have a number of partners that have engaged our tool sets to allow that. The most compelling of which I think is EasyDerm, where the iPad sits and the patient faces and looks at the iPad whilst I look at the patient, and the documentation is occurring, and it's quite visual, but it's listening to me and doing that. For me, that's already patient benefits. We've seen a number of others that are using sort of speech and so forth, engaged with some understanding for remote, telemedicine type or telepresence. The interactions with the sort of the Qualcomm Life, and we're seeing that sort of increasing the monitored me, and improving the tools that allow for this access. And voice is one of those things, but also obviously understanding the underlying content. So, for me, I'm a big patient proponent, so it's important to see that. Obviously, we focused on the clinicians and the paraclinical staff, but I think patients will become an inevitable component to that, and we'll be supporting that with voice and some of our other tools as well.
Yeah, it's interesting. I mean, I think the other one that should be interesting is the web framework for implementing all of these tools, right? Whether it's voice recognition or the other tools, they can be integrated into any mHealth, mobile health application. We'll see how many patient-facing applications integrate that. But right. I mean, I guess you already did that with Siri, right?
Yeah. So
it's a healthcare tool.
Integrating all of that other information is sort of central. We have Florence is our sort of demonstration concept prototype. I've shown that. I think it sort of gives people a sense of what's possible with the inclusion of all that information, and essentially, not turning voice into text, but turning it into medical intelligence that you then, can use for all these other functions. And, some of this I think is just unimagined at this point. I say that on a fairly regular basis. There are things that I don't think we've even thought of that are possible. When the telephone first came out, people said, why on earth would I want to talk to somebody, hundreds of miles away? Now it's sort of this to say, well, actually, we stopped using the telephone. We text every time. Whole separate issue, but that instant communication. If voice and true voice understanding, I would point to Star Trek. I'm a big Trekkie. I can't help it. But when you look at some of the things that we've seen, I had this conversation with one of the participants in the Tricorder X Prize, okay. And interestingly, they had the same upbringing as I did. They grew up on Star Trek, and some of the things, just the naming of it. Theirs is called the Smart McCoy, and they see voice as part of it. I'm still seeing some of that vision and thinking, hey, we're starting to bring some of that to reality. And voice was just an essential part. You didn't see people at the keyboard, although Spock was sometimes clicking buttons, but he was never I never saw anybody type on Star Trek. They always used their voice.
Interesting. Well, it's great chatting with you, and great insights into some important health IT topics. So thanks so much for taking the time to be here.
Always a pleasure, John. Thanks for the opportunity.
All right.